chemotherapy. So take a look at the results. You can look at the progression-free survival. This in gray color and the black color. Very dark color is zafitinib. As you can see, zafitinib is a little bit better compared to the platinum-based chemotherapy. Okay, let's look at the subgroup analysis. The patient, of course, this is the study about the non-small cell lung cancer, adenocarcinoma. The adenocarcinoma having the GFR mutation. As you can see, zafitinib compared to the platinum-based one, much better. You can see the response rate is the more than 70, usually 30% response rate by the conventional chemotherapy. But in patients, adenocarcinoma without the EGFR mutation, as you can see, the black line, zafitinib, is not better than the conventional chemotherapeutic agent. So now we can think that the one-size-fits-all approach, it doesn't fit all. So treatment design for the average patient can be successful for some patients, but not for others. As you can see, the same size of jacket, some is quite tight, some is quite loose. So we need to develop much better therapeutic strategies based on the patient characteristics and the patient's disease status. So 1.5 years back, the President Obama in the United States, he gave some statement about the precision medicine. So he said that if we can find out that the status of disease, like blood typing, ABO typing, or checking the body weight, in that case, maybe we can apply the better therapeutic plan to the patient. So this is about the precision medicine. It is identify which approach will be effective, which patient based on genetic and the environmental and the lifestyle factors. The precision medicine customized healthcare with the medical decisions and practices and the product being tailored to the patient, individual patient. So for the precision medicine, molecular diagnostics, imaging and the analytic software should be developed and should be applied to the patient to decide the best strategy for the patient. So let's go back to the previous one. As I mentioned before, the patient has the adenocarcinoma in the lung at both sides, so we cannot remove both of them. So maybe we can apply the systemic therapy using the ERESA, EGFR inhibitor. So before applying that, we can check the profile of the EGFR. So if the patient has the EGFR in the cancer tissue, we can apply the ERESA, zafitinib. Otherwise, cisplatin-based chemotherapy should be applied to the patient to get the best results. Okay, so we can give right therapy for the right patient. So this is a previous slide, exactly the same. It's just you can see the color. So I think that we can contribute the molecular diagnostics and the imaging to apply the best therapeutic strategy to the patients. Okay, sorry about that. Okay, today's topic is the Theranostics. Theranostics is a fundamental of the therapeutics and the diagnostics. That is just 14 years back, the doctor John Byeong-Cheol, he was the CEO of the pharmaceutical company. He coined this name Theranostics. As you can see, it linked the Theranostics with the diagnostics. So Theranostics was defined as a diagnostic methodology for personalized therapeutic intervention. It customized healthcare. So if we apply this Theranostics to the patient management, maybe we can eliminate unnecessary treatment for patients whom a standard therapy is not appropriate. And then we can optimize therapeutic plan for for the particular patient. So we can approach the individualized, tailored medicine to the patient. Just take a look at the diagnostic FDG PET imaging. As a maybe you might be very familiar to FDG PET imaging. This is the patient. You can see that the patient is an ovarian cancer patient. Unfortunately, the patient has hypermetabolic many lesions in the abdomen. In addition, at the neck area, so it's kind of the widespread stage 4 disease. So maybe the chemotherapy can be the only option to treat the cancer. Anyway, treatment was given, and the patient, as you can see, almost all hypermetabolic lesions resolved. So it's quite good. Another case, clinical situation is exactly the same. Ovarian cancer patient, as you can see, has a metabolic lesion much in the abdominal cavity and the neck area as well. So same therapeutic strategy was applied to the patient. But unfortunately, the chemotherapy wasn't successful to the patient. So it means that it's just a diagnostic imaging. We can find out the lesion, but we cannot predict what will be happen by the treatment. This is that just how the cancer cell take up the FDG. It is glucose analog. So cell membrane, it has the glucose transporter. It is usually highly expressed in the malignant cell. In addition, the malignant cell, it has a lot of the hexokinase, so it can phosphorylate the FDG glucose as well. So the cancer cell, as you can see, is the hallmark, one of the hallmark of the cancer cell. Sorry about that. It might never ring again. I just turn off. So, what did you say? Will you help me to respond by phone? No, just kidding. Okay, so cancer cell, it has energetics is different compared to the normal cell. So cancer cell, it's nature. So we can find out the cancer cell. So we can detect the multiple sites of the cancer in a body, but the problem is that we cannot predict what kind of things will happen by the application of the therapy. So here's the beauty of the Theranostics. About the thyroid cancer patients, the patient should have the resection of the thyroid cancer region, maybe all together with the normal thyroid tissue as well. Chest PA, as you can see, looks fine. CT, again, you can see some node right here, right? Just it is a single slice, so other slice has multiple lesions. So the patient had the radioiodine, and then we got the imaging. As you can see, even if you can just see the couple of nodules at here and the CT scan, but the huge number of the metastatic lesion is growing at the patient lung. At multiple time of the radiation therapy, unfortunately, the patient in a status of the complete remission. So we can tell if this image show that the uptake in the metastatic lesion of thyroid cancer, we definitely can tell that the metastatic lesion will respond quite well by the treatment of the iodine-131 therapy. It's another patient, same clinical situation, thyroid cancer patient, chest PA. You can maybe see, couple of nodules in the chest column, and the CT also shows nodules, not very big. And the radioiodine was given to the patient. Unfortunately, the nodule doesn't take up much about the radioiodine, so we can imagine the patient will not respond to the iodine-131 therapy. The forecast was correct. So within the time, the nodule progressed. So this is that quite typical case of the diagnostic imaging of the radioiodine. So just to compare it, ovarian cancer patient, we can detect the disease with the FDG PET. It's just diagnostic imaging. Here, thyroid cancer, radioiodine scan. Image-wise, very coarse compared to PET-CT, but it has very valuable, things. So it provides what will happen after the application of some type of the therapy. So the diagnostic imaging, it integrated diagnostic imaging to detect the presence of the molecular target for a specific therapy. So in case of different thyroid cancer, the molecular target is that located in cell membrane protein. It is that we can call this is the sodium iodide importer. It usually take up the one iodine along with the two sodium ions inside of the cell. As maybe you know that the NAK ATPase, it will pump out high amount of the sodium. This was delivered inside of the cell by the sodium importer. So anyway, the equilibrium will be achieved. Let me talk about the history of Theranostics. As I mentioned before, Theranostics, the name was just coined after the second millennium. But the basic principle of theranostic imaging was applied long back ago. Okay, let's begin. This gentleman is the Benedict Kaysen. He worked at the UCLA. He invented the automated rectilinear scanner. It is that the prototype of the gamma camera. The principle is exactly the same, and he used that one, and he visualized thyroid using the radioiodine. You can just focus on the paper. This Dr. Benedict Kaysen holds. Let me magnify it. That is thyroid. Just imagine about that. As you can see, this is that 1951. More than 60 years back. At that time, how could we see the thyroid, right? At that time, ultrasound wasn't there, and the CT scan wasn't there, MR as well. Nobody can see the soft tissue inside of the body. Only the nuclear medicine technique can visualize the soft tissue in the body. And he developed that one at that time. This is the therapeutic application of the radioiodine to the patient. His name is Dr. Sauhurst. He worked at the MGH, Massachusetts General Hospital, and he gave radioiodine to treat the Graves' disease patient. It means that high functioning thyroid. You can look at the face of this patient. You can see that the exophthalmic feature. He gave the radioiodine. At that time, there was no method to separate iodine 130 and 131. Nowadays, we use iodine 131. At that time, there is no possibility to just get in iodine 131. So at that time, just use the mixture of the iodine 130 and 131. But it was quite successful to treat the Graves' disease. So still, in the United States, the Graves' disease patient usually got iodine 131, most popular therapeutic strategy in the United States. And then a couple of years back, Montefiore Hospital at the New York, his name is Samuel Sadley, he gave the iodine 131 iodine 130 and 131 mixture to treat the thyroid cancer patient. This is the patient. In fact, the patient had the thyroid cancer a long time back, and then he got the surgery at the neck. Maybe he spent happy days for more than 10 years, and then the cancer recurred. At that time, he visited again hospital because of the thyrotoxicosis. The reason of thyrotoxicosis is that the patient has so many metastatic thyroid cancer reasons. The cancer was quite functional, so it produced a lot of the thyroid hormone. As you can see, the patient at the time quite cachexia, right? Hypothyroid status. He just got the information of the previous doctor Sauhurst. He gave radioiodine to treat the Graves' disease, so he applied the same strategy to the thyroid cancer patients. Several times of the iodine 131 application, as you can see, same person, quite different. In fact, he has metastatic lesion at the skull as well. After finishing several times iodine 131 treatment, the doctors take the treated the mass out, and they analyzed that area using the microscope, and then they could not find any cancer cell at there. So they believed it's the cure of the thyroid cancer at that time. But you can imagine, maybe it recurred again 10 or 20 years back later. We don't know. But anyway, this kind of the experience is quite great one. So the story was published in the Paediatric magazine. So many people read that. So at that time they called it's a magic bullet to treat the disease. So it impacted so much to the social and the political period as well. I think that that kind of the experience make the availability of the radioiodine in the clinics. So couple of, as you can see, this procedure was performed in 1942, and around 10 years later, 1951, iodine 131 was accepted by the American FDA. So nowadays we use iodine 131 to treat the cancer and to diagnose some disease. So this radioiodine theranostics play a key role for excellent prognosis for thyroid cancer, for the diagnosis and therapeutics as well. Okay, let's look into the case. So 43 years lady, and she has capillary cancer. The cancer is quite encompassed with the thyroid tissue, so we call it interthyroidal. Lymph node was not assessed by the surgeon. Before surgery, I don't know, quite bright, but anyway, here is some nodule at here. And the FDG PET visualizes the nodule. It's quite hypermetabolic, so we can imagine it might be the cancer. So after the surgery, histology was like this. So it's capillary cancer. And then, as usual, the patient followed by the physician. Ultrasound was done. You may can see the lymph node here. You also can see that very bright the hilum of the lymph node. So the picture-wise, it's quite great, good. It's a normal looking lymph node. Anyway, the patient had this the imaging study. Iodine 123 in scan was obtained with the patient. Now you can see the intense trace uptake at the middle line. We simply can think that it might be the residual thyroid tissue, but this one is in quite a lateral part, so it may not be easy to consider it as the normal remnants. Nowadays we have a very excellent machine. It's a SPECT CT. So this midline is thyroid remnant, but this one is quite a lateralized one. Maybe you can make this kind of image using SPECT CT. So the ultrasound guided needle aspiration was performed, and even if the cytologic assessment was a reactive hyperplasia, we also done measurement of thyroglobulin using the aspirate. The value of the thyroglobulin is quite high in this patient, so the node was removed, and the final result was the metastatic capillary thyroid carcinoma. So this case provides that the value of the radioiodine as a detection of the hidden cancer in case of the different thyroid cancer. So let me look into another case, a personalized linear therapeutic strategy. Quite a young lady, 21 years old, and the cell type is not very nice. papillary cancer, sclerotic type, is one of the poorest prognostic histology type. Lymph node metastasis was there. Before surgery ultrasound and the CT, you can see that the lymph node with the necrosis in the center, so we can definitely can tell it's metastatic lesion. Surgery was performed, and at the PET CT, you can see some hypermetabolic lesion at the lung. This is the before the surgery, so all the hypermetabolic lesion was resected. Okay. You can see the chest CT. Frankly speaking, it might not be possible to find out the nodule at this CT. Radiography, definitely no. But after keeping the radioiodine, you can see the very intense uptake at the post lung. So it's very micro nodular metastasis. Even we cannot see using the high resolution CT. In addition, you can see that the focal uptake at the right neck area is residual metastatic nodule here. She got the 4 times of radiation therapy. As you can see, a little bit decrease of the radiation uptake there. So quite a response well, but still disease is there. Okay, in this case, with the radioiodine, we can detect the hidden metastatic lesion in the lungs. In addition, we can treat the cancer using the beta-emitting iodine 131. Okay, let us think about what kind of the biological change will be happen inside of the thyroid cancer. So as you can see, a blue color, well differentiated cancer. So anyway, it is cancer. So signaling cascade about the MET kinase and the AKT mTOR pathway is changed in the cancer. So thyroid cancer, this signaling pathway is a little bit activated. So finally, activation of this pathway inhibits the expression of the thyroid related. And then activation of this pathway activate more tumor promoting genes. In case of the poorly differentiated cancer, those signaling cascade is more active, very, very active. So this activity inhibits thyroid-related gene expression quite much, and it activates tumor-promoting gene quite much. So tumor-promoting gene is quite active in case of the full differentiated cancer. So as I delivered before to you, it's hallmark of the cancer. It is that the energetics is different. So it used thyroid cancer, same as another cancer. In poorly differentiated one, it used glucose quite much. So like this, it will take up the glucose much. And well differentiated cancer, it is cancer, but it still has characteristics of the normal thyroid tissue. So it will express the thyroid-related gene, such as the sodium isosynthetase. As I mentioned before, the protein will be located in the membrane of the thyroid cancer cell, and it will take up the iodine from the outside to the inside of the cell. So the well-differentiated cancer, it will take up the radioiodine. The poor differentiated cancer, it will take up the FDG. So people, use this term, flip-flop phenomenon. So well-differentiated thyroid cancer, differentiation is good, generally less aggressive, and responds well to iodine 131 therapy. Poorly differentiated cancer, generally highly aggressive, and it doesn't respond well, iodine 131 therapy. So here is very famous paper. It published 10 years back in the JCEM. And they enrolled quite much patients, 444 patients, and followed quite long, more than 10 years. And then they found that survival. This is the patient having the metastatic lesion which take up radioiodine. In that case, 10-year survival is that 56. But in patient having the metastatic lesion which it doesn't take up the radioiodine, in that case, 10-year survival is just 10%. So they also subgroup about the patient having metastatic lesion which take up the radioiodine. If this iodine abuse region responds very well to the iodine therapy, if we can make iodine negative lesion, in that case, survival will be 10-year survival will be 92%. But some patients always radioiodine uptake will be there. In that case, 10-year survival is just around 30%. So with the radioiodine scan, we can tell how long the patient will survive. If the patient doesn't respond well to iodine 131, we can call the patient as the radioiodine refractory patient. In that case, we can apply the systemic cytotoxic chemotherapy. The therapy was performed more than 30 years, a long time back, but nowadays nobody uses that one just because the response rate is quite low, and then side effect is quite huge. So nowadays the doctors use the targeted therapy, tyrosine kinase inhibitor, so sorafenib or lenvatinib, those kind of things. I had some experience to giving the tyrosine kinase to the patient with radioiodine non-ovid thyroid cancer. Here is the patient having that, as you can see, the metastatic lesion at the lung, and as you can see, TG level is more than 50. After giving the sorafenib, as you can see, the mass is quite regressed, and the TG level goes down, and it acts quite well on the patient. So, by the application of the sorafenib, we can get the progression-free survival more than 5 months compared to just the patient without having that. But anyway, just think about the effect of the radioiodine therapy. Sorafenib just prolong the survival time, like 5 months more or just 1 year more, like that. But the radioiodine therapy is amazing to the patient. I had the experience with this patient. In fact, the patient has 3 times of the radioiodine therapy. As you can see, the year we gave the radioiodine 15 years back, and the last one is the 11 years back. Finally, the TG level, TSH stimulated TG level is less than 2 nanogram, and the patient nodule was there at initial, but at the 3 times of the radioiodine treatment, there was no nodule anymore. So I think that the patient is attained the complete remission. She is still my patient. She always taking the thyroid hormone because she doesn't have any thyroid tissue in her body. And still, she is the complete remission. After this treatment, she married. As you can see, she was in 26 at the initial. After finishing that, she married and she delivered 2 babies. Now the younger baby is around the elementary school student. So sometimes she came to me with her children. So I'm quite happy with the patient. So it's beauty of the iodine 131 therapy to the thyroid cancer patient. So just go back to the thyroid cancer patient, radioiodine refractory. What kind of things we can do? nowadays we are just giving other drugs such as that sorafenib or remibrutinib. The patient should pay quite much money. The cost of the drug for every month is that in Korea is that 2.5 billion won. In the United States, US dollar, it might be $2,100 each month. So the patient should pay quite much. Even the patient is paying quite much to treat the thyroid cancer with the tyrosine kinase inhibitor, but always the recurrence or aggravation will happen. It might be 6 months or 2 years later, like that. Not forever, but already we talk about that complete cure of the thyroid cancer, even metastasize every part of the body, and maybe there should be some chance to clear up every lesion using the radioiodine. So I'm working on a little bit about the basics. So we already discussed about this one, right? So thyroid cancer, these two pathways are active, so it inhibits the expression of the thyroid-related gene. In case of the poorly differentiated one, mentioned before, these two pathways are too active, so not much expression of the thyroid-related gene. Sorry. So, just think about that. If we can block this pathway, what kind of things will happen inside of the cancer cell? So, I just imagine, if we block that, the iodine will have a chance to get the inside of the cancer cell. If that is possible, it might be very easy. Just giving the iodine 131, the beta ray will kill the cancer. So already this study was published by the Dr. Ho, working at the Sloan Kettering IAEA. It was published 3 years back. About the NEJM, nuclear genomic medicine. It's quite famous one. They gave selometrine is tyrosine kinase inhibitor. It inhibits the mechanism pathway. 4 weeks. It's iodine 124 PET imaging. It's just a physiological uptake and salivary gland, and maybe the patient swallowed something. So I think that the salivary activity in the esophagus and the stomach, bowel, everything is a physiology. But the patient has a lot of metastatic lesions, which doesn't respond to the iodine 131 therapy. It means that the metastatic lesions lose characteristics of the taking the iodine. Because of that, this doctor gave selometrine, and then exactly the same imaging was obtained. As you can see, just compare it. Metastatic lesions at here. So we can change the radium refractory thyroid cancer into radioiodine responsive cancer. Still, the effect is not good enough. So we need to develop much better drug which can differentiate the thyroid cancer. So I'm working on it. So many drugs can be applied to make the cancer cell express thyroid-related gene more. So I'm the DCRMS physician. I'm quite interested in molecular imaging. So I'm applying that technology to find out some nice chemical which can enhance the radioiodine ability of the thyroid cancer. So different thyroid cancer, not much, sodium isoporter, but different thyroid cancer, it has a lot of the sodium isoporter, but the differentiated cancer, poorly differentiated one, it might not have much of the sodium synthetase expression. So maybe you can find out the way to express this more using some chemicals, maybe using some other technology, maybe hypoxic condition or temperature and pressure. We don't know which can change the psychiatric. Anyway, we can apply so many technology to change the cancer cell. So for the study, we did develop this lipoprotein. So we just linked the reporter with this promoter. So with this vector, we can measure this promoter activity. So simply, this is more, lipoprotein will be more. This is not much, lipoprotein will not be much at there. It's just comparative one. So quite correlation with reporter and this. So we developed that one, and then we wanted to find out that very nice compound which can increase the expression of this. So let's say patient CT is like that. The radioiodine is gave. There is no ticket there. Nowadays we are just waiting. If the tumor size is big enough, in that case we can apply the tyrosine kinase inhibitor just because it's very expensive. And then it has, so many side effects, such as the skin reactions or sometimes hypertension, sometimes proteinuria, and sometimes alopecia. So many things will happen. So patient usually doesn't want to take, that drug much. So we are waiting until tumor is big enough. People think that around 2 centimeters is a good time to start the tyrosine kinase inhibitor. Or if the cancer is quite nearby the very important organ, such as the great vessel. In that case, they will start the treatment of the tyrosine kinase inhibitor. This kind of thing, just wait until the tumor size is big enough. Just think about that. If we can find out the very, very nice chemical which increase the misexpression, in that case, you don't need to wait. Just giving the drug, and then we can give the iodine 131. And then we will have a chance to eradicate all the metastatic disease from the patient. I'm hoping that day not come yet. So we made those kind of things. So quite complex slide, But anyway, this is the this promoter, and then we can check the effluent. It's the phospholyluciferase. So with the photon signal, we can understand how much this protein will be produced in these cells. So so many chemical was already developed. So in my case, I have 3,000 tyrosine kinase inhibitor candidates. The institution, chemical institution in Korea, they provide the chemical to me. So I developed that cell. So I'm searching what kind of chemical will be good to enhance this promoter activity. It means that the chemical can make more sodium synthetase in the thyroid cancers. So anyway, this is that to find out that you can see that so many wells, and then we found that this chemical is quite nice to increase the sodium synthetase. So anyway, I'm working on it, and then nowadays we select out the 2 chemicals, and we are now in the in vivo study. It is just the in vitro study. So in addition, the result is good, but we don't know. It will happen in the body of the animals. So we are working on the in vivo study nowadays. Okay, this is about the tumor heterogeneity. It is that one of the biggest hurdle for the cancer treatments. Okay. Epidemic study, for patients with the thyroid cancer. You can see hypermetabolism in the neck, and definitely it is thyroid cancer. Unfortunately, the patient has more lesions. You can see here, 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 many, here as well. So this is that actual imaging, CT, and fusion. This lesion, like this, you can see, and also lesion at the spine. This one, iliac bone, huge mass, and here, spine, here, here, as you can see here. So, after the surgery of the thyroid, we gave the iodine 131. And then, this is the phototherapy, iodine 131 scan. You can see here, red iodine accumulate quite much. Here, some there, but here, not that much. Here, I couldn't see anything. So, this two lesion is just the representative lesion having the radiodiene uptake. This lesion doesn't. So, first we can see these two lesions. After the therapy, after the PET-CT was taken again, you can see this lesion, much regressed hypermetabolic lesion. So it means that the response quite well. Those two reasons, like this, not much radioiodine was accumulated at there. Even after the radioiodine therapy, as you can see, in this lesion, aggravated. So, let me talk about the heterogeneity. Even if the patient having thyroid cancer, it can metastasize multiple lesions. We just assume all might be quite pathology and quite biology, but it is not. So, as you can see, two reasons quite well. FTG PET before radioiodine therapy, radioiodine scan, uptake at here, follow, as you can see, not much hypermetabolism at there. But this one, before, like this, unfortunately, no iodine uptake within the time, aggravation of the hypermetabolism. Here, quite well. Here, very poor response. So, this is tumor heterogeneity. So, lesion of the FTG uptake, but no radioiodine uptake. The reasons need additional therapy. With this imaging combined with this, we can tell those lesions need additional therapy. MR, CT, they couldn't. They cannot tell additional therapy will be needed for this patient. But we definitely can tell the patient, some lesion is fine by some treatment, but some lesion will not respond to some type of therapy. So we can tell more, even if the image is not much clear compared to the CT or MR, but it has quite a valuable information it can provide. So same one. Okay, this is the end of my initial talk. Radioiodine Theranostics is a prototype of the precision medicine, and it plays an important role for the treatment of thyroid cancer. And the radioiodine scan, it can visualize the metastatic region of thyroid cancer, and it might be the only method which can accurately forecast the response of the iodine 131 treatments. And it might be extraordinarily helpful to set up patient or lesion-based therapeutic plan. molecular imaging can be applied for high throughput drug screening for enhancing this expression. I'm working on it. Regionalized medicine through the nuclear molecular imaging will play an important role for state-of-art precision medicine in near future. I want to work on it. Okay, this is the last case I wanted to distribute to you. A 41 years old female. The reason of visit is the elevated serum TG, and you can, think that the patient might be the thyroid cancer patient. The patient had the history of thyroid cancer. 1987, she had the subtotal thyroidectomy. As you can see, tumor size quite big, and 8 centimeter, quite big. This is the OP record. At that time, not much computer was there, so doctor just draw this figure. Maybe just time limitation. I would like to tell that the surgeon removed this part, and thus they just remained some part of the thyroid tissue. Maybe it might be they wanted to keep blood supply to the parathyroid glands. Unfortunately, 12 years later, neck mass regrew. So the surgery was given again. At that time, you can see. At that time, they used some typing. Here is mass. Here is mass. Very interesting thing is that at that time, pathologic diagnosis was that the multinodular goiter. Previously, follicular cancer. At this time, multinodular goiter. It's very hard to understand. Anyway, pathology report was like that. No slide remains. Okay. 13 years later, TG level is quite elevated, so she visited me. So I got this imaging. This is the ovary iodine 123 scan. You can see very intense uptake at the neck area, and the periumbilical, some spot was there. So you can see that the TG level, even TSH level is around 1.6, but the TG is quite high. We assume that it might be metastatic lesion. So SPECT CT, same, looks like the lymph node metastasis. Periumbilical, you can see on the CT some nodule inside of the abdominal wall pad. FDG CT, nothing. So aspiration was performed. All reactive hyperplasia, no cancer cell was found. Anyway, second follow-up was also performed, exactly the same as before. So aspiration was performed again. Cytology, negative. But the TG was quite high, so we removed the periumbilical lesion. So it was the papillary cancer metastasis. Still, after removing of the periumbilical lesion, still very high level of the TG level. And then, as you can see, so much iodine uptake lesion at the left, so we just gave the iodine 131. As you can see, it's post-op scan. After that, you can see TG level quite low, less than 0.2. I think that she is in the status of remission. 2 years back, right? Still quite low level. So this patient is that very representative case, which provides the radioiodine might be quite helpful to the thyroid cancer patient to detect the cancer lesion and then to treat the cancer lesion. Thank you so much. Any questions? Please.
Which one is better as a redifferentiation agent? Is it therapeutic or radioic acid?
Your question is that which one is better to enhance the radioiodine avidity to the radiorefractory cancer between the retinoic acid and the salumetinib. Salumetinib is not, I think that still this is not the, what's that? FDA might not, accept it to use that to increase the radioiodine before the iodine therapy, but I'm sure the salumetinib will be better compared to the retinoic acid. I also have some experience to giving the retinoic acid in case of the radiorefractory cancer. Response rate is not very nice. It's around, maybe 20, but still 20% of response is that not the very nice response. A little bit response, a little bit more accumulation of radioiodine. So I'm quite sure about the retinoic acid. Still not very nice.
Primarily, sir, sorafenib is more used better used for bleed infections rather than retinoic acid or salumetinib in most of the cases. Sorafenib is used more for bleed infections rather than retinoic acid and salumetinib.
Excuse me?
I'm telling sir, sorafenib is better. I'm telling sorafenib is better for bleed infections than retinoic acid and salumetinib, and it is can be applied because something is the problem with anti-retrovirus.
I'm not sure I understand everything, but your talk is that maybe we can apply sorafenib to increase the radioiodine activity. Yeah. Some basic research was performed by the various research. Some people use the sorafenib, some people use sunitinib, and so many tyrosine kinase inhibitor was applied to increase the radioiodine activity. So far as I know, the salumetinib is the best yet. Okay.
How frequently you can give
Excuse me?